Thank you all for joining, and I will now introduce today's presenter. Nikita Pozdeyev is an assistant professor with joint appointments at the Department of Biomedical Informatics and the Division of Endocrinology, Diabetes, and Metabolism at the University of Colorado Anschutz Medical Campus. Dr. Pozdeyev is an endocrinologist specializing in the diagnosis and treatment of thyroid diseases, including thyroid cancer. His laboratory uses methods of artificial intelligence, machine learning, and statistical genetics to understand genetic mechanisms of thyroid cancer development and aggressiveness, and develop clinical tools for thyroid cancer diagnosis and management. Thank you, Dr. Pozdeyev, for being here with us this afternoon. I will stop sharing my screen and turn it over to you.
Thank you, Victoria. I am sharing my screen, and thank you for invitation to present today. It's a pleasure and an honor, and I see such a large group of people joining this call. So we'll try to make it useful for all of you. As Victoria mentioned, I'm an endocrinologist. So my primary expertise is in the thyroid cancer. But the concepts on genetic testing, which I will mention today, they apply to most of the cancers. And while I will talk a little bit about research that we are doing in thyroid cancer, that's going to be mostly to illustrate different concepts which we can apply for genetic testing in cancer. And I hope, and I try to make this talk as practical as possible so that you could take this information and apply it to you or to the people you take care for. So these are the objectives, which I believe were listed with the talk. So we will first think of what are the causes for us developing diseases, including the cancer. We'll review the examples of how genetic can contribute to the cancer risk, different types of pathogenic variants, and how the risk can be quantified. And probably the most important piece in the end is how us or our patients can get tested if we think the genetic is contributing significantly to our health. So this is the model for disease risk, and it is not specific to cancer. It applies to any disease that we develop. And the disease risk has different components contributing to it. One is a genetic risk. That is what we inherit from our parents. It's not something that we can modify. This is what we are born with. And there are environmental exposures, of course. A good example would be smoking in lung cancer. We know that the smokers are at a much higher risk of developing lung cancer because of the exposure to carcinogens in the smoke. And this very last Greek epsilon letter, this is something that we cannot quantify. Depending on what you believe in, you could call it a fate, a bad luck, or an act of God. This is just this random events that sometimes we encounter in our life that will affect our health. Think of driving on the highway and getting hit by a drunk driver. This is not something that's under our control, but that also contributes to risk of developing a disease. So now when we have this general understanding of what contributes to us developing health problems, I'll mention that the genetic risk is the easiest out of these three to quantify using the modern technology, because it's a relatively straightforward for us to sequence the DNA, not as straightforward to figure out what to look for in that DNA, but still possible. And I will explain a bit how we can do that. Okay, so different diseases, the contribution of genetic risk and environmental risk is different. So how much it is for the cancer and how we can quantify that. And traditionally, that quantification is done using the twin studies. So as you know, there are two different types of twins. There are monozygotic twins, which are genetically identical. The DNA is exactly the same in monozygotic twins. And there are dizygotic twins, which share just half of the genetic information, similar to regular siblings, brothers and sisters, except the twins are born at the same time. So the idea is that the twins, because they live as a family, they share the similar environmental exposure. So we can exclude that from our risk assessment and just look for a genetic contribution. And if we find that the incidence of cancer is different between monozygotic and dizygotic twins, that would serve as an evidence that genetic plays a role. And there are methods of statistical genetics that allows us to actually put a number to it. How much is the genetic contribution? And a very similar concept are the family studies, where we would compare cancer incidence in genetically unrelated family members, such as husband and wife, and a genetically related, such as brothers and sisters, and use mathematics to estimate contribution of genetics based on this analysis. So now, how much it is in a cancer? The term that geneticists are using to that quantified risk is called heritability. And it's different for different cancers. It's relatively low for the colon cancer. It's only about 15%. For the lung, it's pretty low as well. We know a lot of environmental exposures that plays role in lung cancer development more than the genetics. For the breast, it's actually about 1/3, so it's going up. Ovarian, 39%. Thyroid cancer is 50%, so half. And that's a motivation for the work that we do in my laboratory, because we know the contribution is so high. It's worth studying, and we believe there is a clinical relevance to estimating that 50% of risk. And the prostate, it's even more, 57. And the highest is a subtype of skin cancer that's called melanoma. So it's different for different cancers. What I want to emphasize that these numbers is an average risk if you look at the population as a whole. So if we look, for example, at all Coloradans and calculate how much hereditary factors are contributing to risk of developing cancer, these are the numbers we will get. That is not the same as saying that a particular individual has that much risk, because that could vary. Some might have a very high risk, some might have a very low risk. But when we average the entire population, this is the number that what we will get. So the practical consequence of this distinction is that even if that we know that for the colon cancer, genetic factors contributed little, there might be some individuals who are at a high risk, and the genetic testing might still be indicated, even despite the low heritability for the colon cancer. Okay, now I'm going to talk a little bit about the thyroid nodules, again, mostly for the purpose of illustrating different concepts behind genetics in a cancer risk. And that is what we study in my lab. Thyroid nodules are very common. They are more likely to happen in females. And somebody estimated that if we look at the females above age 60, more than half will have a thyroid nodule on the ultrasound. And only a small percentage of these nodules are cancers. Most of them are benign. But because cancer is a serious disease, we still have to look for those 5% of nodules which require treatment. So how do we do it? We start with doing two things. First, we perform an ultrasound on all patients where we suspect thyroid nodule exists. And then we evaluate the thyroid nodule for the risk features on the ultrasound. And if we think the risk is high enough, then we perform a procedure that's called fine needle aspiration biopsy of the thyroid nodule. So here that lady in red dress is undergoing this procedure. We use ultrasound to know exactly where the needle goes. And in skilled hands, that's a relatively minor deal. It's a safe procedure. Risk of serious complications is extremely low. Although I should say that none of my patients are excited about having this procedure done. Because these are needles in a sensitive area, and it's no fun. We do a lot of these procedures, about 500,000 per year in the United States, because thyroid nodules are so common. So let's see what the outcomes from this procedure is. About 8% of those procedures give us a likely cancer diagnosis. So this is the procedures we want to do because we want the diagnosis that will inform further treatment, usually thyroid surgery. But most of those procedures will give us a benign result, 74%. So those are potentially avoidable. If we would know ahead of time that this nodule is most likely benign, we would not need to do anything. We would just watch it. The biggest problem comes from the bottom two categories. Some of these procedures give us an adequate result, so that's simply unsuccessful procedure. We don't get any cells to look at, despite doing the needles. And indeterminate is when we got a good sample, but the pathologist who looks at the cells under the microscope can't tell what it is. It kind of looks suspicious, but not enough to say it's cancerous. And that is not pathologist's fault. We know that some of the subtypes of thyroid cancer, they cannot be diagnosed on cytology just by looking at the cells. It requires looking at the whole tumor after it is removed from the patient. And that creates a problem because for a significant number of these procedures, we need to either repeat biopsy or do some additional testing, trying to figure out whether it's benign or cancerous. And sometimes we can't tell, and we say, well, our only option is to do diagnostic surgery, which means removing the thyroid or at least half of it. And what we know that many of these diagnostic surgeries, they result in a benign disease. So this is a frustrating problem. Despite all the advances that we have in medicine, we cannot definitively establish the diagnosis before the surgery in a good number of patients. And sometimes after doing all this unpleasant and expensive workup and treatment and committing patients to a lifelong prescription with thyroid hormone replacement, we still get a benign disease, and we could have done nothing if we would know in advance. So this is where the genetics comes, because we know that half of the risk for the thyroid cancer comes from the genetics. So if we can quantify that, then we could significantly improve our risk assessment before we even do anything. And this way, we would prevent some of those unnecessary procedures for benign disease and unnecessary surgeries for benign nodules. So now let's talk a little bit about the genetic concept of gene and the allele. So you probably all know what genes are. Those are pieces of DNA that are responsible for making a protein. So that's kind of a unit of genetic information, which is a functional unit. And we all have 2 copies of each gene because we have 2 copies of each chromosome, with sex chromosome being an exception in males. But most of the genes, we have two copies. And those copies sometimes are identical. We call it homozygous gene, or sometimes they're different. So on this slide, we have two copies of the gene D, which are different. And that individual copy, that individual variation in the gene is called allele. So that's what we are going to talk a lot in the rest of the talk, is about all these different alleles. So this particular chromosome has two alleles. One is small d and one is a capital D. And imagine that the capital D is an allele which is pathogenic, which means it causes a disease. So in this case, the patient who would carry this allele would be at increased risk of developing a disease, such as cancer. So a lot of genetic work and genetic assessment goes into detecting, figuring out what are these disease-causing alleles, and if individual person carries those alleles, and also what to do with those. Okay, so this is a little complicated slide, but I'll try to explain it and make it easier. So those alleles, some of them are common. So if you look at 1 million people, let's say half of the million will have that allele. We call them high allele frequency or common alleles. And some could be very rare. In fact, most of the genetic variation that makes me, and you, comes from this rare alleles, and some are extremely rare. Could be just one copy in 10,000 people, or even less. And some of that variation could be unique to the entire population of the Earth. So, and what usually happens is, while both common alleles and rare alleles can cause disease, the degree to which these alleles increase risk varies. So for common alleles, the increase in the risk is usually very small. It could be just a few %. And that makes sense, because if those common alleles would increase the risk significantly, we would all die from cancer. We would have an epidemic or pandemic of cancer, because those alleles are common and they would cause a lot of disease. So that's not what actually happens. Those alleles only cause a little bit of risk. That's why they survive in the population. And on the other end of the spectrum, we have rare alleles, but they have a great potential for causing the disease. And sometimes we have this pathogenic alleles, we call them mutations, which are effectively guarantee that that individual will develop a disease like cancer. And in case of cancer, we call this mutation and the disease that they're causing cancer-associated syndromes. So when we talk in the clinic about genetic testing, these are the mutations we usually mean testing, although I should emphasize that the cancer risk is not limited to those rare variants which cause a lot of risk. It's spread across alleles of a different size, including those very common alleles which contribute just a tiny bit of risk. And there are methods which we can quantify across all of these different variants and better estimate how likely that individual will develop cancer because of what he or she inherited from their parents. So research-wise, we want to detect those alleles, and this is not easy for two reasons. One reason is the rare alleles, they're just rare. So if we're thinking of rare alleles on the most left, only 1 in 10,000 people will have one, or 1 in 5,000 to be precise, because we have 2 alleles per person. So we need to genotype 5,000 people just to find one version of that allele which we want to test. if it's disease causing. So it's a problem because we have to genotype a lot of people to study those. And the second problem comes from the fact that genome is very big and there are millions and millions of these alleles, which we need to test if they're disease causing or they're neutral, or some of them might be even protective. So that is what statisticians call multiple hypothesis testing. We test so many different alleles, then there is a great likelihood that some of them will be associated with cancer just by chance, not a true association, but because of statistical randomness. And the entire field of science that is called statistical genetics deals with these problems, and that's what we deal in our research. So conceptually, though, if we have data, detecting this disease-causing alleles is straightforward. We just genotype a lot of people and see who develop cancer, and then we see if you carry that allele, you're more likely to develop a cancer. So run a statistical test. In science, we call this genome-wide association studies, when we test multiple alleles for association with a disease. And geneticists figured out a long time ago that, sorry for that, that no single institution, not even a single organization or a country, have enough data to solve this problem. It requires a global effort. That is why we collaborate across many countries, many biobanks, to collect all that massive amount of data that we need to figure out what are these disease-causing alleles. And that's a consortium that we have for the purpose of quantifying the thyroid cancer risk for that clinical problem of deciding which nodules we want to biopsy, which patients we want to operate on, which includes a lot of countries. And this is just the numbers for the thyroid cancer. We study different thyroid disease. For thyroid cancer, we currently have about 22,000 people with the disease and almost 3 million controls. So it's really a big data problem. This is just some statistics of the analysis that we run, multiple biobanks, almost 3 million participants, and we test 100 million genetic variants, those alleles that I mentioned, to figure out a small fraction of them, which are disease causing. And it's truly a small fraction because most of this genetic variation has nothing to do with thyroid cancer. We replicated 26 known associations and discovered 61 new for the thyroid cancer. So we know right now of about 80 plus genetic alleles which we can look for, which will help us to decide who is at risk of developing thyroid cancer. And it works the same way for non-thyroid cancers, for the other cancers as well. And in fact, for any disease which has significant contribution of genetic factors to the risk. So this is what's called Manhattan plot. This is the Manhattan plot for thyroid cancer risk. And you can see why it's called Manhattan, because all those peaks, they look like skyscrapers in New York. But in reality, those are genes. And the taller the peak, the greater the likelihood this is a true association with the disease. And as you can see for thyroid cancer, we see a lot of peaks. These are all different genes which change the patient's risk, put somebody at risk of developing thyroid cancer. Okay, so there is a method that's called polygenic risk score, which allows us to look at all of this different variation together and come up with a single number, which is interpretable, which is what is your risk, how much more likely you are to develop a cancer compared to the rest of the population. And that method is called polygenic risk score. I will skip the technical details of how that is calculated, but we'll go back to that original formula that we looked at which says there are two big contributing factors to us developing a disease. One is genetic, and one is environmental. And we know that even if we have the best possible polygenic risk score, and we discovered all the genetic variation that causes the disease, at best, we can only estimate about half of the risk. And for clinical use, in my opinion, that's not enough. We want to do much better. When we decide whether we want to biopsy a nodule or somebody for a surgery, we need more certainty. That is why the other way we approach this problem is to look also at the images and apply some artificial intelligence methods to combine genetic risk assessment with a polygenic risk score with image analysis, a more traditional way of estimating the risk of that nodule. And I won't go into detail of what all these plots are meaning. Just trust me, we see that if we add the genetic risk assessment to the image analysis, we see an improvement, which is logically plausible based on what we just discussed. Okay, there is yet another applications for the genetic risk assessment. Not only we can say who is more likely to develop disease, we want to know who is more likely to develop an aggressive disease. The thyroid cancer has that reputation of being a good cancer. I put it in quotes, which I think is not true. There's no such thing as a good cancer. But that assessment comes from the fact that most of the people with thyroid cancer actually do well. We treat them and we're able to cure most of the people. We still get thousands of people who are dying each year from thyroid cancer. And if we could say, who are those people who are more likely to develop a bad disease, then we could screen them early, we could treat them more aggressively and prevent a really bad outcome. And we can use genetics to do that. It is a work in progress, but we found that our genetic assessment can predict who is more likely to develop tumor which is multifocal, which means you have not just a single cancer, but multiple foci of cancer in the thyroid. And those who will develop lymph node metastasis and more of those metastases, which is of clinical relevance. What is interesting when I think about this, that genetic risk is defined at a time when the egg is fertilized by a sperm, so very early. And practically, we could calculate that risk at birth. So it is sort of a fortune telling, except that it's scientific. For Harry Potter fans, I'm thinking of the work we are doing as a divination for thyroid cancer. So we predict the future of what those patients will likely to develop, or those kids will likely to develop as the life goes. It is not a very precise science, but divination is not known to be a very precise science. And as we learn more about the genetics and environmental risk, our assessments will get better and better. Okay, so I'm now going to switch gears a little bit. So we were talking about this more common variants in the right part of this plot. Now I'm going to talk about cancer-associated syndromes. This is what is even more important because this is what we know in a clinic how to test. And it's much easier to test than calculate this polygenic risk score and all this fancy research stuff, which is cool, but not yet very practical. We look at these mutations, the syndromes which are causing thyroid cancer. And we discovered 3 genes which have this known from previous study pathogenic variants which cause disease. And one of them is multiple endocrine neoplasia, which causes a rare subtype of thyroid cancer called medullary thyroid cancer. And we looked at the big population, at 250,000 whole genome sequences from the All of Us research program. And we found that indeed, this pathogenic variants in the red gene and some other genes significantly associated with thyroid cancer. So it is known from previous research, so we didn't discover anything new. But what we found, that these variants are much more common in the All of Us population than we are thinking based on what's known in the literature. For example, multiple endocrine neoplasia is estimated currently that 1 in 35,000 people will have that variant in a disease. We found that actually way more people in the population carry that pathogenic variant in this gene. And we also looked at the other data set just to make sure we are not fooling ourselves. And this is reproducible data. And we found that in UK Biobank, this is 500,000 people living in United Kingdom. The prevalence is also actually much higher. What was interesting that when we looked at the clinical manifestation of these mutations, only a small fraction of these people were diagnosed with thyroid cancer. So what we know right now, that there is a large pool of people living with this genetic disease who are not aware that they have it. And they might develop a disease at some point later in life, but some of them may die from old age without even knowing that they have a disease. So not all of these variants will end up with a disease, but it's beneficial for us to discover these carriers because then we can monitor them. And should they develop a cancer, we could treat it early. And this is again, this is a complicated slide, but please don't try to read through it. This is from the guidelines, which tell us if you find those germline mutations in the red gene, what you should do. And the current guidelines recommend that if you discover this mutation in children, you should consider prophylactic thyroidectomy, pretty strong treatment when you recommend removing the thyroid, which will eliminate the risk of developing thyroid cancer later in life. What do we see in our research? That these mutations are relatively common, and a majority of the people probably will not develop the thyroid cancer. So we vote for changing these guidelines, and instead of subjecting those children to thyroidectomy, thyroid surgery, and need for lifelong thyroid hormone replacement, we think we can monitor many of them without operating. There are some variants in this gene, which are here on top, which are associated with a very high risk. And in these patients, thyroidectomy would be indicated. But most of those people, most of these children should not be operated on, contrary to what's currently recommended, in our opinion. In adults, we generally watch them. And I have several patients like this in my clinic, and we rarely recommend thyroid surgery because we know all these adults, most of these adults, despite having a genetic disease, will likely do well. It's not working like this for the other cancers and for the other genes. Sometimes these mutations could be pretty nasty and indeed increase the risk of developing cancer quite significantly. Okay, so this is my last thyroid slide. I think I troubled you enough talking about my research, so we'll go to thyroid cancer in general. But I wanted to show you this. This is the Michelangelo's David statue. I think many of you recognize this. And this gentleman has a goiter, which was very accurately replicated by an old master. So it's a common disease. Okay, so now let's talk a little bit about the other cancers. And I'm sure you recognize this is a famous actress, Angelina Jolie, who was diagnosed as a carrier of BRCA1 mutation. So BRCA, there are two genes, BRCA1 and BRCA2, that greatly increase your risk of developing breast cancer, ovarian cancer, and some other cancers as well. And it's relatively common. It's not a very rare disease. And Angelina Jolie chose to undergo a procedure, which is prophylactic double mastectomy, which means both of the breasts were surgically removed to prevent developing thyroid cancer in the future. She did not have thyroid cancer. It was done to prevent a future thyroid cancer. So quite a dramatic treatment, but it is potentially life-saving. So you may ask yourself, well, if she had this disease and she got treated this way, should I get tested as well to make sure I don't have the mutation and don't die from a breast cancer later? And a full disclosure, I'm not a breast cancer expert, so I had to look this up preparing for this talk. It turns out this is a very complicated decision, and there are many risk factors which would prompt you or your primary care physician of testing you for this mutations. And I've listed some of them, and the list is incomplete. But in a short sum, if you develop breast cancer at a young age, consider testing, consider genetic testing. People of Ashkenazi Jewish ancestry, they are at a much higher risk of carrying this mutation. Males rarely develop breast cancer, but if they do, it's quite possible that it is genetic. If somebody has multiple breast cancers, maybe in both breasts, or recurrence later in life in the other breasts, this is a risk factor. Some other cancers, like exocrine ovarian or metastatic prostate cancer, should make you think of genetic testing as well. Family history is important. If you have relatives who got cancers at a young age, or multiple family members who develop a disease, or if they had a high-risk ovarian, prostate, or pancreatic cancer, maybe there is one of those mutations running in your family, and you could be at risk. And of course, if your family member was diagnosed with one of those genetic cancer-associated syndromes, then you might be at risk because you might have inherited the same mutation as well. There are other indications. This is not a comprehensive list, but it should give you an idea if you are at risk and if you should be tested. Okay, so we just talked about two cancers, thyroid and breast. What about the other cancers? It turns out that there are mutations which put you at risk for the other cancers as well, such as colon, for example. And there is an association that's called American College of Medical Genetics and Genomics, which looks at this variation in the genome and saying, this is the one which should be acted on, which means the patient should be informed that they have this, and some kind of treatment or surveillance should be done. And it's a relatively small gene list, and it's not only include cancer. There are other diseases, the heart diseases and the cancer syndromes, which are worth testing for. And if you discover mutations in these genes, notifying the individual that he or she is a carrier. And the last slide I want to show is what are the ways you can get tested for all of this? Because this is not what we typically do in clinic. Your primary care is not going to test you for all these 100+ genes to find out if you are at risk. And I think it's important for you to consider if you are at the genetic risk of developing these diseases for yourself, because you might change of how you live and how early you get screened for cancers. And it could be potentially life-saving, but also for your loved ones. Because if you are diagnosed as a carrier of one of those pathogenic mutations, there is a 50% chance that your child has it too, got it from you. And there is a chance your parents might carry those mutations. So it's quite an impactful on your life if you found to have one of those pathogenic variants. So if you want to get tested, what are the options? And I think this slide, even if you think all the previous talk has been boring and you didn't really learn much, maybe this slide will justify spending 1 hour listening to me. The most traditional way that you can get tested is to talk to your primary care physician. And if indeed you meet certain criteria and your primary care physician thinks you might have one of those pathogenic variants, then you'll get referred to clinical genetics. Usually, primary care doctors don't test for genetic syndromes themselves because it's complicated and it's usually out of scope of practice for primary care docs. There are a few caveats with this route. First of all, not all primary care physicians are facile with what's considered to be risk features which justify that referral. The second, the demand for clinical genetic services is so high that it's actually quite difficult to get an appointment. You might have to wait for a long time. And there are, of course, issues with an insurance coverage as well. So if you don't want to go that route, what are the other options? The second option is direct-to-consumer testing. There are companies there, you will pay for the test and they'll collect your DNA and they will run it and give results back to you. The two obvious downsides of that route, first, it will cost you money. Those tests are quite expensive. And the second, the quality of the testing varies. You don't really know what you're getting for your money, even though currently FDA requires review and approval from this direct-to-consumer genetic tests. So there is a third way, which is not very well known, but I think it's potentially the easiest out of this three, where you can enroll yourself in the research biobank study. So Colorado Center for Personalized Medicine, which we have here at the Anschutz Medical Campus, runs a biobank. It's not actually a pure research biobank. It serves a clinical purpose. And anybody who is receiving care at UC Health can enroll into this research study. Once you sign a consent, next time you get a blood draw for a routine clinical need, you will also get a sample taken for DNA sequencing. And at some point, it will get analyzed by the biobank people. And they look if you have one of those pathogenic alleles on that American College of Medical Genetics list, which I showed on a previous slide. And if you happen to have one, then you will get a phone call from a genetic counselor, Emily Todd. So your participation is free. And there's one way that you could screen yourself for whether you have some actionable genetic alteration, and which potentially could change very much of how you approach your health. But let's say you're not in Colorado. There is still an option. Many large healthcare systems have their own biobanks, but there is also a large research program that's run by National Institute of Health, which is called All of Us Research Program, which does the same thing. And anybody who lives in the United States is eligible to participate. And the program is actively recruiting. And once you consent, you will get a saliva kit and you contribute your DNA by spitting in a tube and sending that saliva back, and they are looking at the 59 genes on that ACMG list. And if you happen to carry that mutation, that includes BRCA1 mutation that Angelina Jolie had, then you will know that. And then you could take that information to geneticist or to your primary care doctor and discuss what action should be taken to decrease your risk of developing a bad cancer. And all of us estimated that among those people who consented for this study, about 2 to 3% had one of those pathogenic variants, and they got that report. So this is a least known way. It's not a traditional clinical way of getting genetic testing, but it is free and it works. So you may consider it. And this is my last slide. I want to thank you all for listening, and I hope you found this useful. And we have some time for questions, I believe.
Thank you, Dr. Pozdeyev, for an excellent presentation. We do have about 10 minutes for questions, so feel free to unmute yourself or put your questions in the chat. We will start with one. So Dr. Pozdeyev, you referenced, you can calculate cancer risk at birth, and sometimes a carrier for a disease may not ever develop the disease in their lifetime. Can you speak a little more on if there are any special ethical considerations when using genetic risk scoring in these cases?
There are certainly ethical considerations and risks. And I can mention a couple. And one I've already talked about is the risk of over-treating. We don't really know frequently what is the clinical risk and what are the likely clinical outcomes for some of those mutations. And as in the case with multiple endocrine neoplasia, we might be tempted to send children for thyroid surgery while they may do just well without it, and that's a problem. There are many ethical considerations. For example, not all ancestry groups or ethnic and racial groups have the same access to care. And if, let's say for the whites, it might be easy to get some testing. For the other underrepresented groups, it may not be as straightforward. There's also variation in the genetic risk by ancestry. So a big problem in the genetic research that most of the genetic data we have comes from Europeans. So because I developed the model using European data, it will work best on the Europeans, and it may give us a false result if I apply it to a Black individual or a Latina. So that's just a few, and we can continue talking about this, but I want to get to other questions too.
I realize it was a loaded question. We could probably spend a whole nother hour on that topic, so thank you. There is a question in the chat on false results. So thinking of what is the likelihood of getting a false result with the kinds of testing that you mentioned, whether that's saliva or through blood?
Yeah, so there are two types of false results that we can think of. One is just a technical error. When you have a mutation and the company runs a test or a laboratory runs a test and they miss it. Nowadays, that's pretty unlikely because this technology and the next generation sequencing that is used for this is now very advanced, and the quality control pipelines which are used by qualified labs are very rigorous. So that is unlikely. The second problem is harder to deal with. That the problem is that we don't know all of the pathogenic variants that can cause disease. So if you look at the databases, a lot of these variants they are labeled as VUSs. We call them variants of undetermined significance, which means we might detect them, but we don't really know what to do with those. Are they increasing your risk? Should we start screening you for cancer at an early age? We don't know. And that's a big unsolved problem in genetics.
Great, thank you. We did have a question submitted on Lynch syndrome testing. Could you give a brief overview on what that is, or when or how it should be used?
Yeah, so Lynch syndrome, relatively common cancer-associated syndrome. There are 3 genes, which are DNA repair genes, that when there is a mutation that destroys the function of one of those genes, then you get a Lynch syndrome. I don't want to give a clinical advice on this simply because I don't see a lot of people with Lynch syndrome. That would need me to look at the guidelines to give you an accurate information. So I'll pass on who should be tested and when.
Great, thank you. And then one more question from me, and we'll see if any others come through the chat. So let's say any of those on the call decide to get tested. How should they use those results with their provider? Like, how does that impact clinical decision-making and patient management?
So it really depends on the variant, because the management would depend on what disease you're at risk for. The easiest would be to take it to your primary care and say, well, I have this genetic syndrome, so what I should do? And that information probably would result in a referral to a specialist who knows exactly how to deal with this. So, for example, in my clinic, I deal with those multiple endocrine neoplasia patients. It's a highly specialized problem. So you need somebody who really focuses on the problem. So there are other people who knows how to deal with the Lynch syndrome. So knowing those people and referring to a proper specialist in a large healthcare system like ours is the best way to do, because this is not an easy medicine. It's a very complicated medicine. Yeah, the other thing, what I would recommend, if you get that report, let's say you enrolled in a biobank, and you get a report that says you have this genetic disease, and this is a gene that's mutated, talk to your relatives, because some of them may have that too. Consider whether you want to test your children. These are all complex decisions, so you might need help from a genetic counselor before you go that route. But those are important, life-changing decisions, in my opinion.